in idiopathic generalized epilepsies.
Yeah, thank you, Klaus. I was initially planning to keep it a really short talk, but then before the session, Klaus told me that if I run over time, he's going to stand in front of me and turn really red, and I think we all want to see that. So I really hope that we're going to get a lot of questions so that we can push him to that point. The work that I'm going to present here was done during my PhD under supervision by Professor John Terry, and it's collaborative work with the group from King's College with Professor Mark Richardson, who's sitting over there. And at the basis of this research, there's a particularly nice and elegant data set from people with idiopathic generalized epilepsy, IGE. I think in general, IGE is sometimes regarded as getting a little bit less attention than the symptomatic types of epilepsy, and this might be due to the fact that people think there's not as many cases of them, although it's reported there's 15 to 20%. Some papers report actually 25%, some even a third, whatnot. And another remark that's usually being pointed out is that it's believed that people with IGE respond relatively well to anti-epileptic drug treatments. So it's a collection of disorders. The most famous ones that you're probably familiar with are the childhood and juvenile epilepsies and myoclonic epilepsies. Seizures mostly associated with it are the absences myoclonic and tonic-clonic. What's really interesting is that they have no structural brain abnormalities, and that when you test them psychologically or in terms of intelligence, they are what you would call normal. EEG is typically used in the diagnosis, and I think with quite some success. I think it's very abnormal that a person with IGE that is untreated will have a very normal EEG. But recently there was a nice review paper by the group of Mark Cook that also shows that things are never as straightforward and that there's also focal discharges sometimes observed in IGE, which complicates matters, as always, in epilepsy. Anti-epileptic drug treatment, even though successful, is typically lifelong. And moving forward, it's very common to observe a family history. So brothers or parents that have epilepsy. Onset, it's quite typical during childhood. Also, I do also think that sometimes later during adolescence or adulthood it can start, and people might actually grow out of it. So when we're thinking about this as a phenomenon, then we're really pushed towards thinking about networks in this sense, I believe. And the mechanisms of seizure expression, because they are generalized seizures, involve a large-scale networks. And if we're gonna, want to ask the question like, but what is it in the networks of people with IGE that increases the susceptibility to seizures, whereas their, first-degree relatives are unaffected, or the healthy controls are unaffected? What is it in their networks which makes them so different that they support the seizures? If we want to do that, it's quite natural to use the data from EEG, because this shows us large-scale reflections of brain activity. And if we want to compare the networks, functional networks from people with IGE towards their first-degree relatives or healthy controls, then there's not a lot of sense to start looking for interictal or ictal discharges because, the healthy controls and the unaffected people, they don't have any epilepsy. So what we did, or what they did, is select resting state epochs of activity, which allows us to compare those different cohorts. So I'm going to show you a very boring picture, just to illustrate what such an epoch might look like. These epochs are selected by 2 EEG experts from King's College, so artifact-free, no discharges. So this would probably be the exact opposite of what a neurologist or a clinical neurophysiologist would be looking for when they would be trying to diagnose someone with epilepsy. And what I like about this is that before we do our mathematical techniques, if you just were to eyeball it, I think it would be really, really hard to say, like, okay, this is a relative, or this is a control, or this is a person with epilepsy. I don't think that a neurologist or an EEG expert would be able to do that. But with our techniques, we can interrogate this data and we can reveal properties which you cannot immediately eyeball, which allow us to discriminate and to reveal the networks which are generating these type of activities, patterns. So the EEG was conventional 10-20, resting state activity, which means the eyes closed, and they're told to be relaxed, I believe. Artifact-free, no abnormalities. The data numbers are quite good. So we have 35 people with IgE, 32 unaffected first-degree relatives, and 40 healthy controls. The IgE is a mixed bag. So we have the childhood types, the juvenile types, but also some generalized chronic types. Neuromedication, the usual suspects, I would say. Different doses, of course. And of all the people with IgE, 19 of them were able to become seizure-free due to this treatment, which in this context means, I believe, longer than 1 year, no seizure. And 16 of them had still ongoing seizures. So the cohorts, IgE, relatives, and controls were selected such that they were, the means of the age and the sex were, similar. So how are we then going to study this? I'm lucky that I'm presenting on Wednesday, so a lot of the methods that we used have already been touched upon. For example, in Klaus's technique, Klaus's tutorial, these things have been pointed out. So we first filter the data in the frequency bands, and we're going to try to represent this image that I showed you, and we're going to try to represent that by topology and network topology by using a network derivation technique. In this context, a recording electrode becomes a node, and the strength between those nodes, correlation-based. You can pick your poison, pick your method that you like. What we did is we choose a rather straightforward and simple one-to-phase locking factor, which gives you a weighted value between 0 and 1, 0 meaning that 2 electrodes are really not so synchronized, and 1 that they're really synchronized. So what we end up with is a 19-node network. They are undirected, they are weighted networks. Again, similarly, if I just were to show you a network like that, I don't think anyone would be really able to see something interesting with that, but then we can use graph theory to pick out the relevant features in there. So how do we do that? This is very much in line with the work of Rubinoff and Sporns. We pick what is typically regarded as the hallmark graph measures, so the mean degree variance, clustering coefficient, and characteristic path length. We use the brain connectivity toolbox. This is a really nice toolbox. I can advise anyone to use it. They have all the flavors, the undirected, directed, the weighted, the unweighted. So it's really convenient. And what we do is that for every subject, for every frequency band, we can compute those 4 measures. Then, for every frequency band, we can compare the means of an entire cohort and compute the standard average, which allows us to compare those results. Now, I think Dean Freeston already pointed out on Monday, when we're doing those kind of things, we got a couple of frequency bands, we got loads of measures, we got loads of people. We are going to find something, probably. So we got to punish ourselves, we got to be honest, we want to know, is this really an effect that tells us something that has value? So we're going to do the Kruskat-Wallace test, and we're going to Bonferroni correct. It might still not be fully ideal, but I think it's a harsh way of verifying or validating our results. So here's an example. Focus a little bit more on the alpha low frequency band, because this is where we mainly find the results, which might not be so surprising because it's resting state activity with the eyes closed. So this illustrates what I was just trying to describe. To the left, we have the entire control cohort with the means and the standard error, and then in the middle, the people with IgE and the relatives. One of the worries, of course, because it's just based on 1/22nd epoch, is how robust is this? So we had a master student, this is very preliminary results, a master student called Simon Todd. Look at this, and what he did was really quite nice. he took the epochs which were selected by the experts from King's College and was like, well, okay, we can now use this as some kind of like standard and sweep through longer recordings and see if we can pick up more resting state activity and, you know, make the same kind of computations as we did before to ensure that these results are not completely, you know, random and variable. And this is indeed, even though preliminary, verified. So the main result picture, this is the only frequency band where we found significant differences. It's the low alpha frequency band. The main results are up here. So on the top, we have what I just described for all the 4 measures. And what's really quite interesting and important in my and in our eyes is that if we look at the mean degree, that cohort, the mean degree is actually significantly different, statistically different from the healthy controls as well as the first degree unaffected relatives. What's more is that when we look at the mean degree variance, it's the people with IgE and their relatives together which are different from the healthy controls. But the IgE people and the relatives themselves are not significantly different. Same holds true for the clustering coefficient, not for the characteristic path length. We can then, if you remember, we can then subdivide this group of patients, or people with IgE, sorry, because we had 19 of them being seizure-free and 16 of them with ongoing seizures. So what we can do is, okay, we're interested in those networks. How do people, you know, maybe we can address the question of the seizure-free people, study their networks and see how they've enabled themselves to become seizure-free. So we subdivide those groups into seizure-free patients and ongoing patients. The disadvantage is that now the numbers kind of drop, so our statistical analysis becomes a bit more tedious. And in all fairness, we do not find strongly statistical results there. But what is interesting, and perhaps one of the things that we can discuss, is that when we look at this, that the seizure-free patients actually do not look as healthy controls at all, which is something that if you were to make a naive hypothesis initially, you would perhaps assume that if you become seizure-free, your networks or your functional networks would start to look more like those of the healthy controls. But in fact, our preliminary analysis of that does not really support that. So how am I for time? Still at 5 minutes? Okay, so then I'm going to spend the rest of the conclusion, discuss the results. So if we do our comparison across controls, people with IgE, and relatives, the way we summarize it, the way we look at this in the figure, is that we have found what we can call an endophenotype. And this endophenotype is characterized by this set of graph measures that I just showed you, mean degree variance, and clustering coefficient. What is an endophenotype? I think it's a concept from psychiatry, neuropsychiatry maybe. It's been shown in schizophrenia. And it's a way to address the fact that we, you know, the genetic underlyings of idiopathic generalized epilepsy. So it's a heritable trait which is a component of a disorder or associated with an increased susceptibility to develop the disorder. And in our results, just remember the people we were analyzing here, some of them had juvenile, some of them had childhood absence, some of them had, you know, tonic-clonic and whatnot. We actually show that for this rather rough group, collection of IgE syndromes, we can find such an endophenotype. So we can find these significant differences. The networks of the unaffected first-degree relatives are different typically than those of the healthy controls. But if you think about it, unaffected first-degree relatives are healthy controls. They don't have epilepsy. Some of them might, in some rare cases, develop that, but to our knowledge, they are healthy controls. So in that sense, it's a necessary but not a sufficient condition, and this is something that Professor Giunteri already pointed out yesterday. If we were to take these results and treat them as biomarkers, then they wouldn't be particularly useful in terms of allowing or supporting a diagnosis, because they were not able to discriminate in quite some cases, the networks from first-degree relatives from those who actually have IgE. To address that, what we have done in our group, and this is again very much a collaborative effort, this has been work by Helmut Schmidt, George Petkov, Mark Goodfellow, Mourinho, supervised by Jill Terry. Actually, Helmut and George had posters up on Monday. They'll still have those posters with them. So the more elaborate modeling results which have been built on this are described in those papers and posters. So if you're interested in this, I very much advise you to either come up to me or to them and to discuss them. However, the main value of the results, it's not like it was not intended as a diagnostic or classifier. It was intended to study the networks which support seizures. So this finding of endophenotype, I think, is very interesting and could be very informative for future phenotyping and genetic studies. Thanks for your attention. I think I'm still on time. Thank you.
We have time for many, many questions.
Yeah, well, I also have had one fundamental problem with this approach is what basically you are analyzing here are not the real connections. These are apparent connectivities. Actually, you are analyzing the correlation matrix between big mixtures of signals. So these are not really sources or anything.
Yeah.
So the question is, why do you then choose for topological analysis? I mean, this is not a real topology. Why don't you just analyze the matrices themselves as mathematical objects? I mean, this would have been the most adequate approach, I would say, if you would have a really underground structural connectivity, like internet. There's all these measures in between centrality and whatever they are borrowed from actual information networks in principle. So my question is, why did you choose to analyze the topology, the geometrical the topological properties of the networks and not the matrices of the correlations themselves?
I would say pragmatism.
So it's an evidence-based, let's say.
Yeah, I would say that we're trying to find differences, and even though you're right, it's not structural, it's not anatomical.
Take the eigenvalues of the correlation matrix or some other invariant.
Yeah, we could have.
Close.
Yeah.
Also take the sum of the rows and Another question.
We could, yeah.
Oh, so I was just wondering if you localized on the EEG where this change was. The reason I ask is because it's pretty well known that people with primary generalized epilepsies have posterior slowing intermittently on EEG.
Yeah.
And I just was wondering if that.
Yeah, well, even though I would like to be careful with really, because it's a symmetrical measure and because it's quite crude and whatnot, I would be careful in reinterpreting and putting it back to the anatomical location. However, we still do that, and Helmut might be able to tell you more about that, because he used that quite a lot in this Kuramoto-driven approach. For us in this stage, it wasn't as important. We didn't really report it, but we do sometimes find particularly robust places within the cohorts where these differences occur.
Yeah, I was just thinking you're finding this in the alpha range, and that's mostly
Yeah.
posterior.
Yeah, it's true.
It's a very simple question. Were any of these cases, or have you looked at any which are drug naive? Are any of the studies, or any of the EEG reporting is done in a drug naive state?
No, we would like to, but no.
So
If you have that data,
in
then
a sense that what you could also be looking at here is an endophenotype of somebody on medication.
that is true. Yeah, that is true.
Still, I was thinking that, right, with the relevance problem. And they had that
But the differences are.
That could be just an effect of the antiepileptic drug.
Yeah, well, I mean, that is something that we would like to. No, of course not.
So it can't rule that out. Yeah, but if you see the difference between patients and the relatives, it could also be an indication of the drug. There's a difference. In one measure.
Yeah.
Okay.
Yeah.
Yeah.
No, but that is something that we would really like to address in follow-up studies.
Yeah. Similar along the lines, I was wondering if you look at simple power in these frequency bands, like if you look at all the sensors, or do you need to actually go to these like higher order graph already power gives?
Sorry, can you repeat that?
Just the power of in the frequency band.
Yeah.
I'm wondering if you looked at this, if you really need to go to these like higher graph measures or already the power and the frequency, that already gives you similar results.
It doesn't give you similar results.
That's my question. Yeah, if you looked at the power.
But yeah, well, initially we looked at the power, but it wasn't as strong as these results.
But there was.
This did contain additional information.
I was wondering whether you looked at the patients who were the relatives, and if they had any EEG trays that they didn't report having symptoms on, because often patients don't report when they're having absences. So that would make a differentiated group. So that you've got the IG group, you've got the relatives, and they're called not having the endophenotype of having epilepsy. What about the endophenotype of having an active EEG tray? Because we often do see that in unaffected siblings, that they might have the EEG tray without, in fact, having the diagnosis. That would be a differentiator in phenotype maybe better.
Yeah, I'm sorry, I'm a little deaf. I didn't hear that.
So I've announced that. So 2 of the 14 relatives had spinal injuries.
Oh, yeah.
Assuming that the brain is functionally, structurally connected and that there are no isolated nodes, how strongly are your results influenced by the fact that your method doesn't distinguish direct from indirect interactions?
Sorry, from?
Direct from indirect interactions. Whenever I have a connection, it will be picked up, and it's
not
necessarily a low weight or a strong weight that is assigned to it. So the question is your cluster index basically dependent on, and how strongly is it dependent on your method and your weights? That may or may not be correct.
What we have done is we have computed the results, also, for example, for Klaus's measure, the delayed coherences. And we do find similar results. But I've tried to show some robustness. We have tried to use multivariate approaches to overcome that, but yeah, they open up an whole new box of problems which are far from straightforward. For example, in the paper of Wang by Victor Jurasa's group that came out this year, I still think it's really hard to pick measures which go against that problem that you described. Would you not agree?
In your processing pipeline, did you consider the effect of volume conduction between EEG signals, because it might introduce a significant spurious connectivity between them? Maybe the connectivity is not reliable without considering the effect of volume conduction.
Yes, sorry, I'm really deaf. I didn't hear that again. Sorry? So, the volume conduction. No, I don't think volume conduction is taken care of in this method. However, it is taken care of in the method by Klaus if you use an approach that was dealt with by Stam, which we've done as well, and we got the similar results, very robust. So it's not necessarily in this one, but we've tested it.
What kind of reference of montage did you use here? What kind of montage did you use?
10-20. 10-20 against an average. 10-20 against an average reference electrode.
Unipolar montage.
Yeah.
Okay.
Your preliminary result of the seizure-free patients was intriguing. I wonder if you have any further thoughts on that.
Well, I wonder whether you have any thoughts on that. I mean, what I'd be careful about is, like, obviously we're just using a method, an approach. It's a mapping, and we do find differences. So I'd be more inclined to start with a study that addresses that from the beginning and that allows you to formulate a hypothesis as like, okay, what type of changes would we expect to find in the seizure-free patients between the ongoing patients? However, Our data, we were just having trouble getting good follow-up data and drug-naive data to really start addressing those questions, but I would be really, really interested in that.
Sure. I mean, just a comment on that. I mean, one possible hypothesis would be that if you had some dynamic abnormality in a region or regions, then one way to compensate for that is to actually alter your connectivity. So that although that connectivity doesn't appear normal, it compensates for abnormal dynamics in the regions. So actually you could see an abnormal network along with abnormal dynamics that supports normal function. Might be one way, or one hypothesis.